That's the take home there. All righty. So and now we're going to kind of lapse into the B12 story. And again, we're doing the absorption, malabsorption, and the biochemistry diagnostics of B12. So it starts, you ate some meat, that's where you're getting your B12, and you had that salivary R protein, haptoquerin. Right now we come into the stomach, and in the stomach, the parietal cell will release hydrochloric acid, and the chief cell release pepsin, and these are going to be involved in digesting the protein. And in that process, it's going to release B12, which is going to bind to that salivary R protein. Now, we also know that the parietal cell release intrinsic factor that's present in the stomach, but the intrinsic factor, which is going to carry B12, does nothing in the stomach. So in terms of requirements, we'll keep track up here. We need a parietal cell. All right, so now we get to the intestine, right? Duodenum, pancreas releases trypsinogen to trypsin. Trypsin then releases salivary R protein from B12. B12 binds intrinsic factor. What is intrinsic factor? Glycoprotein that protects B12 from digestion. So that's the role of the pancreas in B12 absorption. Small role, but it plays a role. You can get B12 deficient. Lastly, the whole thing then heads down to the terminal ileum, where there's a receptor, the ileal receptor complex, where B12 is absorbed, intrinsic factor release, and B12 travels in the circulation, attached to its carrier, transcopolamine, off to the liver, and ultimately to the bone marrow. That's the story. All right, so that's B12 cobalamin absorption. So now we'll just backtrack and say, well, what can go wrong in this process, right? So malabsorption, terminal ileum disease, pancreas disease, failure of the parietal cells. Right, so here's the major derivatives. And this was a question we just asked. So here was our low back stiffness that I was alluding to yesterday with Crohn's. Low back stiffness improved with activity, right? That's spondyloarthropathy. And perianal fistula got you to Crohn's disease again, so clearly Crohn's. Decreased proprioception. Smear shown, there's your hypersegmented PMN. So this is a B12 deficient patient because they have neurologic manifestation. And so which explains the abnormality, but what is B12? B12 is a water-soluble vitamin, right? This patient may also have problems with fat-soluble vitamins as well. Vitamin E, neuromanifestation, yes, but they should have hemolysis, and it doesn't do anything to cause that hypersegmented PMN. Again, that's the importance of the hypersegmented PMN. It's the language of B12 deficiency. This question, I don't see on the boards, but this is really just like an adverse effect of metformin, which is a cause of B12 deficiency. Why is it a cause of B12 deficiency? Because metformin interferes with the ileal receptor complex. So patients on metformin, you do have to monitor for B12 deficiency. All right, reduces levels by 25%. And again, there's B12 deficiency, but these, of course, are on patients who are on metformin long-term, because we just said it's going to take a long time to become B12 deficient. All righty, that's the terminal ileum, working our way back up, pancreatic insufficiency, more with fat-soluble vitamin deficiencies. So this patient went for sleeve gastrectomy, took out a portion of the stomach. They lost parietal cell. Which of the following complications? Motor vehicle accident at night, right? Vitamin A, bruising, vitamin K, fragility fracture, vitamin D, muscle cramping, non-specific, right? You're losing the parietal cell mass, you're not absorbing B12, sensory ataxia. The neurologic findings, symmetric. They're going to describe it as numbness and or gait disturbance. Pernicious anemia as a cause, so loss of parietal cell function. This, I am not going to do it again. We clearly killed this yesterday, just naming the antibodies on this slide. The antibodies are a marker of disease, but it's a lymphocytic CD4 cell-mediated immune response. So those are the causes. We had parietal cell failure. Among the parietal cell failure, we said autoimmune, but proton pump inhibitors also put you at risk. It's related to the acid, not because of its effect on the parietal cells. So those are the players. And let's get to what you need to know with my version of biochemistry. And this is important as it relates to diagnostics. Just remember, B12 is a cofactor in two reactions, homocysteine to methionine, but it also works in the mitochondria, methylmalonylic to succinyl-CoA. So it's a cofactor there, and if you're deficient, that has diagnostic implication, deficient in the mitochondria. Here it is again, the methyl tetrahydrofolate, inactive, becomes active after losing the methyl group. That methyl group is instrumental, homocysteine to methionine. B12 is the cofactor. Just in terms of, again, the second pathway that doesn't exist for folate, is not folate, it's what it does in this mitochondrial function, and that methyl manoleic acid to succinyl-CoA facilitated by B12. So you need that really because this is all about the diagnostic testing. And this is the feature that they like to do with B12 deficiency. So if you're B12 deficient, they don't ask about succinyl-CoA, but they can, that's down. But really what goes on is this MMA level is increased. So that's unique to B12 deficiency. So deficiency of folate or B12 is the other arm of the pathway. No B12, or if you're folate deficient, elevated homocysteine levels. And you can measure those. We don't really get methionine levels. So you get an elevated homocysteine level with B12 or folate deficiency. But if you're worrying about B12, you can also get an MMA level, and that's the distinction. Folate won't impact MMA, B12 does, and that's a subtle point in terms of diagnostic testing. All right, so now we have a patient, you're worried about B12 deficiency, what are you getting? B12 level, homocysteine, MMA level, and of course you're getting a folate level because you don't know at that point that they're folate deficient. CBC we talked about, antibodies, if you're worrying about pernicious anemia, antiparietal cell, anti-intrinsic factor. And then the other more subtle pathology in the B12 questions is the bone marrow. And it sounds scary the way they describe it. We don't normally get a bone marrow, but if they include it on a question, hypercellular, right? It's reactive, it's being driven. Large erythroblasts, also called megaloblasts. That's where the megaloblast comes from. And it's the idea, again, failure of nuclear maturation, but the RNA is working fine. So you have ineffective erythropoiesis at a nuclear level, but the cell membrane is still being synthesized, and that's why you wind up with the macrocytes. In terms of diagnostic testing, Schilling Test, I'll spend 2 seconds on that. Treatment, they'll get B12 supplements. Schilling Test in brief, what do you need to know about this in case it shows up? And the only relevance of the Schilling Test is it reiterates just the physiology, right? So the first step in a Schilling Test is you replete B12 because you're measuring either excess B12 or B12 that's going to be detected in the urine. So if they're B12 deficient, technically it's all going to be absorbed. So you have to replete B12. So you give people IM B12, then you give radioactive B12 orally, and then you collect the urine. So again, if it shows up in the urine just after you give them an IM repletion, it was a dietary deficiency, step 1. If it doesn't show up in the urine, you go to the next stage, step 2. And in that instance, you give, same thing, the replete, you give that radioactive B12 plus intrinsic factor. And if it corrects, that tells you that the patient has parietal cell failure, autoimmune gastritis, or pernicious anemia. If giving intrinsic factor plus the radioactive B12 doesn't correct it, well, then you have an absorption problem and typically a terminal ileum issue. Okay, the only, the Schilling Test, few and far between, you're going to see it, but it just underscores the physiology, and that's why it was worth reiterating. All right, and then just lastly, why do cells enlarge? I already just said this. This idea of dyspoiesis, so the cytoplasm grows while the nucleus DNA doesn't. Right, so these are the B12 and folate story. The other thing that causes macrocytosis, reticulocytes, they're bigger than red cells, associated with hemolytic anemias. We talked about alcohol and liver disease, myelodysplasia, not getting into, but that can also give you macrocytosis, immature forms. All right, lastly, and this is coming back to that diagnostic testing we talked about. Here's the alcohol user, presents to the ER. You order a CBC, the hematocrit 32, MCV is large. You notice the hematocrit was a normal 6 months ago. So that's the language of folate deficiency, right? They gave you hypersegmented PMNs, macrovalocytes. So we know the patient has folate deficiency, and they're just asking how you diagnose it. Well, it's not a methylmalonic acid level because that's for B12 deficiency. You would have to get a homocysteine level. So homocysteine could have been B12 versus folate, but we have the short timeline. So that's the other tough derivative related to B12 folate diagnostic testing. And that's it. And that's just a reference slide for those of you who love this pathway. Okay.